So I don't know if you know this, but it's a medicine.
Yeah, but okay, I'm on SSRIs, right? My SSRIs do not have a significant chance of making me infertile. They do not have a significant chance of changing my outward physical characteristics.
Irrelevant.
You can't compare SSRIs to puberty blockers. That's
Irrelevant.
apples to oranges. That's a dumb argument.
It's annoying when people spam cap locks, but yeah.
Oh my God, so true. Hello, are you here to debate?
Yes, sir. What's up?
Chilling. Can I get your name, age, and pronouns, please?
Name is Tomris, Tomris.
All right, age and pronouns.
Can I just do late 20s to the age? I don't want to give my exact age, but late 20s.
Yeah, that's fine.
All right, and then I know you said the pronouns thing is a litmus test, so I don't really like using pronouns, but I'm a dude, so I guess he, him would work in that context.
All right, I just want to point out.
Perfect.
This is not, we don't have to talk about it. I just want to point out that in telling me you don't like using pronouns, you did use a pronoun.
Yeah, so I understand what pronouns are. I understand the pronouns predate the transgender issue by quite a bit. I just this whole thing where like it's like pronouns and then like he, him, or they, them, and she, like that's a very recent thing that I don't agree with. So that's why I had to air that out. But that being said, I understand what the context is. So yeah, he, him is fine.
Cool.
So the I think gender affirming care for minors, I think that's pretty much, I guess you could say empirically not a good thing. We could go down that road if you want to. Yeah, I mean, I think
definitely go down that road.
One more time?
No, yeah, I was saying, yeah, okay, I definitely want to hear your argument for that. Go down that road.
Yeah, so the last data that I saw, it's approximately 80% of children under the age of 18 who identify as some sort of transgender grow out of it into adulthood.
So I'm sorry to cut in already. This is like a famous study.
I didn't finish the sentence.
I know, but you're already citing something that's well known.
For those, okay, what are you saying? What?
I'm just saying that study is well known, and there's massive methodological problems with the study. Like, it is like a meme in the community that people only seem to reference the study from your position. But go ahead and finish your thought.
Well, even if it's not 80%, even if it's, I mean, I would say it could even be under 50%. If it's, 30 or 35% of people who identify as transgender when they're children outgrown into adulthood, I'd say it's incredibly irresponsible.
It's 3%
to provide
actually.
medical intervention that is a lot of the times not necessarily permanent, but isn't reversible either, right? Like there's lingering effects of it after you're done, be it for puberty blockers, be it for taking, hormones or whatever. Those effects are designed to impact you for the rest of your life. So the idea that we're going to do that to people who, for all intents and purposes, could grow out of it into adulthood is, if you're following the Hippocratic Oath, is completely irresponsible and unethical and should not happen in the United States.
So real quick,
I'm happy to let you know. Oh, sorry. Okay, go ahead.
No, I just want to point out that like when we look at the actual, like as of 2024, there hasn't really been a study more thorough than the study that I've pulled up on the screen right now, which is re-identification with birth registered sex in a Western Australian pediatric gender clinic cohort. So, to my knowledge, there hasn't been one with as much with as many participants and over as long a period of time as this one, which used 552 participants over a 6-year time frame. And what they found is that in all of the cases of people desisting, which would be 93.1% of the desistance cases, which out of 552 participants, that was 27 participants. So what's 27% of 550? Hold on.
Wait, I'm sorry. You're saying that out of the 500 some patients that you're talking about, 27%?
No, 27.
No, not.
Is that what you're saying?
27 patients.
27 patients. 27 patients out of 552 desisted.
Which accounts for what percent?
27 is 4%.
27 people out of 500 some, that would be about 5%.
That's 4.89% of people desisted. Of those, only 1% of them, and that would have been 2 people, desisted after being prescribed any puberty blockers and or hormones. So if you have a study that's more thorough than this one, and used more people over a longer period of time, I'll gladly read it. But to my knowledge, we haven't gotten any study that's as thorough as this one yet. And this one
Yeah,
shows that desysting is going to be about 5% of the population.
And just to
So two things
to hit home,
go ahead.
sorry, can I just jump in? I really want to finish the thought I was trying to bring up earlier. The problem with the study that you referenced also, there's massive methodological flaws, including how they described people who were trans in that study and who they counted as desisters, because there was both people who ceased attending the clinic were counted as desisters when they actually had no reason to believe that those people did not continue to identify with a given gender, and it was people who attended the clinic who were signed up for, consented with their parents and all of that stuff. So it's not anyone who attended the clinic, but were considered participants of this study. So you're talking about a lot of people who display any sort of gender aberrant behavior. Their parents are bringing them to this clinic, and then they're being considered trans for this study. Yeah, no, it would be really obvious that cohort would have like an 80% desistance rate, because you're not actually diagnosing people for being trans there. You're just observing people who attend a gender clinic. Like, it's not surprising to me that the majority of people who have a thought about gender early on probably don't end up being trans. But as Jovan pointed out, a lot of other studies that we have, including some things like from the Americans for Transgender Equality and the, what was the other organization that did one? Josie Caballero had a big part in organizing that study. Showed that it was like less than 1% of people were desisting. I've seen high estimates of 3, low estimates of like 0.02, and Jovan just brought up one that was like, it was like 4%, you said?
4.89.
So yeah, I mean, and that's so much lower than a lot of other uncontroversial medical practices. So, I mean, if you want to complain about like regret rates and things like that, I'm fine with that conversation. I just don't find it very honest when that conversation focuses on trans healthcare, which is not particularly unique in this way or controversial in this way. And this is a problem with medicine, like kind of across the board. So, but that's all I had to add to that.
Okay, so you guys have said a lot. So I'm not gonna, we can go down the medical study route if you want to. That's just, like, we can do that, and I'm equipped to do that. That's just very boring, and I think that kind of misses the point of what we're trying to get at.
Well, just responding to the study you brought up.
I'm just trying to speak from a place where we can at least, agree with each other in some sense of the word. Would you agree with me that it's relatively easy, not in all 50 states in the United States, but in places like Washington and Oregon, for example, and California, would you agree that it's relatively easy for like 16-year-olds, for example, to get access to like medicine, to medically transition, like generally speaking?
No.
Like, for example, I know someone in real life who they started publicly identifying as transgender, and within a month they were on not puberty blockers. Within a month they were on testosterone blockers, and they were on like feminizing hormones within a month. And that wasn't in any of those states, that is said. Which, like, that I would consider a month turnaround for that to be pretty quick.
No,
would you agree with me that that's generally the case?
No, as of 2023, only 2,084 California children received gender reassignment procedures from 2019 to 2023. So no, I don't think it's that easy if only 2,000 kids are getting it in a span of 4 years.
That's not the question I asked, though, because I said that
Well, yes,
it's not a matter of how many children are doing it.
Well, yes,
it's a matter of how quickly you can get access to those hormones.
If it was easy to get access quickly, more children would be on them.
That doesn't make sense, because you're saying more children would be on. There isn't a benchmark for the amount of children that would normally get hormones. So saying that it's only like 2,400 or whatever, that's not being compared to anything else. You're just saying that number.
I know it's not
right?
being compared to anything else. I'm saying that 2,084 children over the span of 4 years is what, 500 kids a year on average? So 500 kids a year are receiving this, but it's supposed to be this easy thing to get, and they get it super quickly. No, the problem, what actually happens is there are long wait lists for people to even be seen in a gender clinic. Second of all, California still goes under the WPATH standard, which requires 6 months of consistent, persistent, and insistent gender therapy to get diagnosed with gender dysphoria. So no, I would disagree based on your anecdotal evidence of a person you know that it's easy to get gender affirming care or to get like hormone blockers or pubertal suppressants in California because you say it is.
And it looks like there's about 9 million kids in California. And we know that trans people usually figure out to be about 1% of the general population. So that's already 500 per year would be massively under the amount of kids who probably are trans in California every year.
So there's no historical like benchmark to say that 1% of the population is trans. I'm not saying you made it up. That's something that our culture has made up. If you look at India, which is for all intents and purposes the most quote unquote transgender affirming culture in the history of the world, where you have these, if you debate transgender politics a lot of the time, you probably know about this, but in India, you have these things called hijra, they're not seen as women, but they're biological men, right, who are born with like the male reproductive system, who as adults, which they don't tend to do this until they are adults, but that's beside the point, they will transition in adulthood and they will wear women's clothes, take women's names. Oftentimes they will marry men and not think of themselves as gay because of it, right? And this practice has been around essentially as long as Hinduism has been around. So it's been around for thousands of years. There's two things. Number one, hijra in Indian society, up until today, they're not considered they're not considered women in the way that like a lot of like American leftists would consider transgender women to just be women, like point blank, right? They don't consider them women in that sense of the word. And number two, hijra make up less than 0.1% of the population of India. Like, so you like the idea that like the natural population of people who are transgender is 1%, that has no historical.
So that's coming from census, whatsoever. By the way. I just looked it up.
Where do you think, Chris? Where do you think when we say we get the number, it's 0.6, so we round up to 1, right? So where do you think we get that number from? Do you think we're just like pulling it out of our like badukis, or?
No, I'm sure there's. I mean, if you're talking about children in particular, I'm sure there's child psychologists that have made studies about that and stuff. Yeah.
Yeah, so it's specifically going from data from the behavioral risk factor surveillance system, the youth risk behavioral system, and then just using statistical modeling which we use for everything to predict like how far something will go. So I would just say, like you're saying, like there's no way to know if that number is 100%. I would say, well, yeah, that's any number that you have predicting how, like if we were to say how many Christians are in America, right? We can't say that for 100% certainty. We use models and statistical evidence to sort of make an educated guess.
Okay, that's valid. And I kind of just want to bring it back to the issue of children, because regardless of if, let's just say that you're true, or say that you're right, like 1% of the population, give or take. I know you said it's 0.6, we can round up, right? If 1% of the population is transgender, and we're going to go off of children explaining how they feel, right, to their care providers, to therapists, whatever, right, to determine if they are transgender or not, is there anything else in medicine that we allow that kind of like anecdotal evidence to be provided to
lots of
provide
things.
People with treatments that can affect them for the rest of their lives? And if there are, can you please tell me?
Pain, depression, anxiety, lots of things. Yes. Pain is one of the biggest ones. Pain is a completely subjective thing. Doctors prescribe pain medications all the time, which can have lifelong implications for somebody's body. I have multiple family members who have massive addiction issues because they were prescribed painkillers for treatments, and now they can't stop taking them. Pain is a big one. Completely subjective, completely clinical diagnostic.
False equivalence.
Can you demonstrate the false equivalency?
Okay. Yeah.
Yeah, sure. So if let's say I break my leg, right? I'm in a lot of pain from. It doesn't have to be something physically you can see like a break. I agree with you. It can be something completely subjective. You go to the doctor, you say my leg hurts. Even if the doctor sees your leg's completely fine, the doctor, I think normally something has to actually be wrong with you. But right, the doctor can give you OxyContin, for example, right? The goal, like if the doctor is being ethical, right? The goal of him or her, right? The goal of him or her providing you OxyContin isn't for you to get addicted to it, right? Getting addicted to opiates is a side effect of being prescribed opiates, and most people who are prescribed opiates do not end up being addicted to them. A large portion of people do, and that's not okay, that's not good. But the purpose of opiates, when prescribed ethically in a medical setting, is to stop pain. It is not to get addicted to opiates, right?
I'm not seeing
Look,
how
if you
that's
just
a
let me
false
finish my
equivalence
point really
because the
quick. I
purpose
didn't
of
even finish the point I was
taking
saying.
gender affirming care is not to regret it. It's to be one of the statistically likely people who are going to benefit from the care. So I don't really see what the false equivalence is.
Yeah, so because I didn't finish my point, so you don't see what the false equivalence is. The thing with gender affirming care,
Yes.
especially if you're talking about things like hormone blockers or puberty blockers, is the goal of that medication is to disrupt the reproductive status or the reproductive process of your body. It's to change that in order for you to develop other characteristics that you otherwise would not develop.
Well, yeah. Why is this?
I don't think that's a very honest way to
medication.
describe what's going on.
Wait,
I
but
think the goal is to
let's-
improve somebody's quality of life.
But wait, Arden, let's just say it is. Let's say that's exactly what's going on. What's the harm?
Yeah.
Why is it a negative? Why is it
'Cause the
something we
harm-
shouldn't do?
Yeah. So, but going back to what I was just saying, the harm of opiates, right? It isn't that you don't feel pain anymore. That's not the harm. The harm is that you get addicted to it, right? The thing with hormone blockers with like puberty blockers and hormone blockers and stuff is that the harm is the purpose of what they're prescribing it for, right? The purpose of that medication it's to improve the quality of life. I agree with you, but the way it improves the quality of life is by messing with your reproductive system and how it develops. That's the point of the medication.
Yeah,
right?
you didn't demonstrate a harm here. You said the harm, so now you have to demonstrate why that's harmful. You just said it's harmful.
It's harmful because if that child, right, who identifies as transgender when they're a child, if let's say when they're 20, 21, 22, right, if they stop identifying as transgender, there is massive harm being done insofar as now you have a cisgender person who, knowing what they know then, would not have gone through any of these medical interventions, who now has a lifelong medical problem that was completely avoidable, that was done electively for a problem.
That's a risk for all medical interventions, though. There's nothing unique about gender affirming care that has that risk.
Wait,
that's
but all I want to point out is how low does the regret rate have to be, the detransition rate have to be for us to say that this is a harm and that we should restrict care for the majority of people?
Well, it's a harm at any regret rate, and the reason for that is because we don't, as a society, right, we don't allow children to make these kinds of decisions. There's no, there is no other, wait, hold on, let me finish, please. There is no other thing that a child could choose to do, whether it's regards to their health, whether it's regards to voting, to doing substances, to making life decisions, anything like that. There is no other situation that we allow children to voluntarily enter into that has these kinds of ramifications for their life.
There is actually.
Like
no,
what?
that's such a lie.
If a child gets pregnant,
like what?
If a child gets pregnant, we allow them to stay pregnant, even though pregnancy has a litany of risks and complications, especially the younger you are.
If a child has cancer treatments regularly impact fertility for somebody's entire life. They cause lots of health problems while you're taking them.
Hold on, but I also want to point out we absolutely do let children have sex. What are you talking about? Anyone under 18 can have sex. Like under 18, like you're saying it's illegal for 16-year-olds to have sex?
The age of consent in most U.S. states is 18. Yes.
The age of consent is what age you can consent to an adult.
I mean, if you're talking about children having sex with each other, I'm pretty sure that's a legal gray area. There is no.
No, it's not. It's not illegal for a 16-year-old to have sex with another 16-year-old. It's quite literally not illegal.
It's not. Even if it's not expressly stated to be illegal, it is not like that. That's not something that's encouraged by any sort of medical institution in the way that gender affirming care is, like, at all. You can't compare those.
You can literally go to any doctor's office and get prescribed pregnancy,
birth control, condoms,
when you're 16. They'll give you birth control because they're like, yeah, you're gonna have that. We literally teach sex ed starting at like 14, 15 to teach kids how to do it safely. What are you talking about?
I kind of want to go back to also, Tomris, is that your name? Yeah, okay. So I think you're completely wrong that there's no other thing that children can do with regard to the health that has these kind of ramifications. There's things in all sorts of ways that have these similar effects that you're not here complaining about. But did you say that any regret would be a problem in your eyes?
I mean, yeah, you could go down the regret road, but like the bigger picture is that no, children, we should not give children the agency to make that.
Wait, can you answer my question though? The one I specifically asked you, did you say that any regret of these procedures would be a problem for you?
Yes, because children should be having them in the first place. Yes, any regret.
Okay, so okay, that's all I needed. You said yes. So how do you square medicine? Because all medicine has significant potential side effects for every treatment that exists. There's not a single treatment that exists in the entirety of medicine that is free of risk. So are you saying that because people can regret treatments and they all have risks that we just like, what would the logical conclusion of that be? Is it only for trans healthcare that we care about risk, or do you care about risk in general? Like, do you actually have that value consistently?
I care about it when it's regarding people who we generally speaking don't consider having their own agency in that regard, which is children, right?
So do
Like,
you
for
believe
example,
we
right,
shouldn't give kids
if
birth
So
I-
to be
I'm
clear,
an
kids
adult,
aren't
right?
consenting.
Okay.
To be
Hold on.
clear,
Please let me
kids
finish.
aren't
I let
consenting
you
to
go
any
on
medical
for a very long
intervention at all.
time, and now
Kids
you're just interrupting.
assent, and their parents consent on their
Arden
behalf.
is responding
So
to what
this
you just
isn't
said.
unique. Again, this isn't unique about trans medicine at all. All medicine, kids are not consenting to. All medicine carries risks and potential long-term side effects. Again, like if you take fucking chemo treatments, that has a massive impact on fertility, and that causes a lot of people to be completely infertile for the rest of their life, but they need that treatment. That's just a side effect people acknowledge, maybe unfortunate, but is a necessary part of improving this person's quality of life and making sure that they're healthy and get to live to see a long life. So are you actually holding a value of regret and side effects, or are you singling out trans issues specifically?
All right. So if I respond to this, are you going to interrupt me again, or are you going to actually let me make my point?
If you say something that's objectionable, probably.
No, because I let you say things that are objectionable this entire time, and I didn't interrupt you. So please just offer me the same
You
respect.
can pipe up.
And then you can keep a mental tally of all the objectionable things I say, and then after I'm done making my point, you can make that. That's how a conversation works. Okay? So if I,
Wow,
as an
thanks
adult,
for that.
right? Oh my God, dude. Okay. If I, as an adult, right, want to get an elective procedure, such as plastic surgery or something, or chemotherapy for that matter, right? I, as an adult, right, can make an informed, consenting decision as a sovereign person, right, to have that procedure. And then, for example, right, if I have some risky, like, plastic surgery procedure and then I have some complication because of it and my life is, like, permanently altered or I die, right, it's, generally speaking, it's okay for me to do that because I'm an adult and I have my own agency, right? Assuming that it's a voluntary thing, right, where I'm physically going to be okay, right, if I don't have that procedure, it is logically consistent that we should not allow children to do it. So the example that you made with chemo, right? If a child has like cancer and it's a serious kind of cancer and it's reasonable to assume that they're probably going to die if they don't receive chemotherapy, right? It is completely ethically valid to give that child chemotherapy because any of the negative things that chemotherapy could do, such as infertility, such as losing all your hair, such as getting a secondary cancer from being exposed to radiation, which happens all the time, right? The risk of all of those things happening is like the damage from those things happening is less than that child dying, which is the whole point. So the only way, right? The only way that you're going to be able to make this point that providing gender affirming care to children is a net positive is if you're going to have to prove to me that most of those children are not going to survive into adulthood if they don't receive treatment.
Does
And
the
I'm not just
threshold need to
asking
be
you to say,
most?
oh, like, you know, they're going to be sad and they're going to kill themselves. I'm asking you to provide like a logical, empirical.
Because who cares about if they
because
kill
that's the only way we
themselves?
do things medically in this country.
Let me just interrupt here. Because you have a fundamental misunderstanding of how medical care is done in this country. You just have a fundamental misunderstanding. Children don't need to consent to medical care. They assent to medical care. And they only have to assent. They only are required to assent at like 14. Prior to that, they don't consent or assent. Their parents consent. So you can make the claim, well, I don't think kids can consent to this. Great. I also don't think kids can consent to medical care. That's why their parents do it. So it's not about whether or not the child can consent. That's a non-argument in this standpoint. Because again, it's a medical procedure. So the parents consent to all medical procedures for a child. Now at 14, you typically need to get assent, which is just letting the child and getting an acknowledgement from the child that the child understands what's about to happen. But like, again, legally in our medical system, parents consent, not children. So the whole premise of the beginning premise of your argument is flawed.
Okay. No, that's 100% valid. And I can respond to it incredibly quickly. Just like if that child, let's say the age doesn't really matter. It's a child, right? And they're under their parents, like what you just said, right? Their parents, I don't know the term you used, but their parents will make medical decisions on their behalf, right? If I'm a parent and I want to make a medical decision for my child that is objectively harmful or objectively is more harmful than the potential good, the state absolutely has an obligation to step in and stop that parent from doing that to that child. Absolutely.
Yes, but you have to prove the harm, which you have not done.
The harm is that the reproductive system is like forever altered, possibly destroyed. That's the harm.
But again,
your reproductive
that's
system
not
is not
unique.
destroyed.
That happens in lots of medical interventions. That's what we're saying. You're not showing something that is unique about this medical care that is a particular risk.
Arden, I just want to point out your reproductive system is not destroyed from going through puberty blockers and HRT. So I don't know what.
Yeah, not necessarily. There can be some reduction in fertility on certain cross-sex hormone treatments, but generally not on hormone blockers. Usually your endogenous puberty will resume like 6 months after if you choose not to pursue cross-sex hormones. And we haven't seen any significant decrease in fertility for those people. But regardless, like even if it does impact fertility, again, lots of treatments impact fertility long-term. And as you pointed out already, we consent to those because there are other risks, and we've decided that that person's life, their quality of life, is more important than necessarily their capacity to reproduce. And usually kids are informed about this before they assent to these medical procedures, as well as the parents. And the same thing is happening with trans medical care. We've decided that better than them killing themselves or having an extremely low quality of life is allowing them to transition and potentially choose to risk their fertility on cross-sex hormones. That is something that people are being informed of, and they're being informed of at age-appropriate stages to make those decisions.
Yeah, I mean, I just wouldn't say that the age of 15 or 16 is age appropriate to make that kind of decision, like point blank, period. So unless, like you said,
but we're
something
back,
like chemotherapy,
Thomas,
we're right back to if they don't receive it. If they're
we're right back to this. We're right back to you going that they
right?
can't make that decision. We're back to that argument, but that argument doesn't hold weight because they don't make the decision themselves. Their parents and their doctors are making the decision.
And why should anyone care what you think is age appropriate? I want you to bring evidence that it's not age appropriate. I don't care if you think it's not age appropriate. That's not relevant. Unless you're a researcher and you have research and you're trying to convey that to us.
Well, no, because I'm saying that just by this, I feel like we're talking in circles, right? That just by the same logic, right, that a parent cannot have their child go under a medical procedure that is not absolutely necessary if it's going to harm them, right? By that exact same logic, we do that for everything else. And I know you said there's all these other medical things that we do that causes children to lose their fertility. I'd like to hear about one besides chemotherapy, or besides another thing that is like an extremely niche, extremely specific thing that like the child is going to die if they don't receive it. I agree. If the child is like empirically like probably going to die, right? And I'm not talking about from like social ostracization or something. I'm talking about like their body will stop functioning if they do not receive this treatment. It is completely ethical, right, to give them a medicine that's going to stop their reproductive system from working, or that's going to give them like a secondary disease or something, if it means they're not going to die. I 100% agree with you in that case. And that's why, again, we let children get chemotherapy, because we're saving their life. That's okay, right?
I feel like your answers are getting a little circular.
Hold on.
You just talked for fucking 4 minutes, dog.
Self-report. You have not given me anything that children self-report, that as a result of that completely subjective self-reporting, we give them medicine that causes their reproductive system to be altered, if not stop working. There's no other way that we. There's no other avenue.
This is the issue. This is the issue here. One, your answers are getting completely circular. They're getting completely circular. 2, when we're talking about justifying the removal of healthcare, we don't have to justify. You have to justify the removal. You have to point out the harm. Now you're saying, well, the harm is that it can alter their reproductive system. Okay, why is that harm? Why? Like, who cares? Like, if you have a kid who doesn't give a shit about ever getting pregnant, or doesn't give a shit about ever having biological children, then there is no harm. The harm is all of a sudden, the harm is completely gone now.
Not true.
Yes, it is.
Not true.
Where's the harm?
And I'll tell you why. Because children change their minds, right? I'm pretty sure.
I've never changed my mind about wanting kids.
Study that says children change their minds, like if you really want to, but just empirically, right? Or excuse me, subjectively, right? When I was, say, 16, right? I didn't want to have children when I was 16. Most 16-year-olds don't want to have children, right? Most 16-year-olds want to either play video games or play sports or hang out with their friends or do whatever, right? That's what 16-year-olds want to do. To have a 16-year-old, right, tell you, I don't want to have children. Yep, you can do all this stuff to me because like, I'm not planning on having children. So if my reproductive system gets, damaged or possibly, doesn't work in the future, that's fine because I don't want to have children. A 16-year-old telling you that does not negate the fact that it's entirely possible when that kid's, I don't know, 10 years older, in their 20s, 20 years older, in their 30s, whatever. That does not negate the point that that child can have or adult at that point, right, can have an incredibly significant blow to their quality of life because they realize as an adult, like a bunch of people do, right? As an adult,
potentially, but you don't get to decide that for them.
And now I can't have children.
You're just making speculative
that's
arguments.
So ridiculously irresponsible.
You're making speculative arguments.
What are you talking about?
This is a speculative argument. You're saying, well, we shouldn't do it in case they get older, and in case when they get older, they change their mind. Even though right now they don't want it. Right now, what actually will benefit them is going through this care because that's going to benefit quality of life in a litany of ways. But because there's a chance that they may want kids in the future, they shouldn't be able to go through this. They shouldn't be able to actually get the help that research shows will actually benefit them because there's a chance they may get. It's just a speculative argument. And it doesn't. And it's anything.
Like that's just your feelings. Like why? Like sure, it doesn't matter. Even if it's true that they could change their mind, you don't get to decide that for them.
Let me ask you a question.
Absolutely,
let me ask you a question.
Make a decision regarding limitations on medical intervention for children. That absolutely is something the state does.
What age do you think kids should be able?
That's not what I said.
Hold on, real quick. What age should a person be able to have bottom surgery? What age?
18. Well, I mean, if you're asking me personally, 18. I'd put it higher than that. But like 18. Legal, like generally speaking, for the sake of this argument, 18.
Got it. So at 16, they can't decide if they don't want kids, but at 18 they can. What significantly changes in the brain, or even at 17? At 17 they can't decide that they don't want kids in the future, but at 18 they can. What significantly changes in the brain function between a 17 and an 18-year-old?
It's not in brain function. As a society, that's what we've determined.
So it's just an arbitrary line in the sand.
You have the ability to make those kind of
decisions. Yes, it's just an arbitrary line in the sand of when we say.
No, it's not arbitrary.
Yes, it is.
No, it's not.
If you can't demonstrate the relevant change between 17 and 18, it is arbitrary.
No, and I'll tell you why. Right, the age of consent in most states, is 18.
Yep.
Hold on, I'm making.
I'm not talking about the age of consent.
Right.
We're going on something that's irrelevant. That's why he's interrupting you.
No, it's relevant for the exact same reason, right? The age of consent is 18 because by and large, right, most 18-year-olds, as we've determined as a society, are emotionally developed enough that they can make a consenting decision to have sex with someone. It's not like when they're 17, they can't, and then when they turn 18, all of a sudden the biology of their brain changes and they can. That's not how it works.
This is not what I'm talking about.
Determination.
Thomas, you are not talking. You're Thomas. That's not what I'm talking about.
Same thing with medical
That's not what I'm talking about.
This is functionally him doing
It's literally
so
not
he can have
the
time
argument
to think.
I put in front of you. That's not the argument I put in front of you.
You guys are talking over each other. I can't hear what you're saying.
That's not. Yeah, because you're talking about something that's not the argument I put in front of you. It's not the argument that I made. The argument I made, you said the reason why they shouldn't be able to get this procedure done is because what if they change their mind in the future? And so I'm asking you, what is the difference between them getting it done at 17 and them getting it done at 18?
That they're legally an adult.
Great. So it doesn't actually matter about the harm. The harm doesn't actually matter in this. No, it doesn't. Does the harm go away? You just said
it's about the legality.
It's about the legality, but the legality is informed by the fact that there is a certain point where we allow people to make bad decisions, right? If you're a 40-year-old man and you want to drink alcohol every day, you shouldn't do that. And if you're 16, we're not going to allow you to do that. But generally speaking, because we value sovereignty and independence as a society, I'm going to allow an adult to make a bad decision that could possibly end their life, right? I'm not going to allow a child to do it because we, generally speaking, agree that children don't have the best judgment in the way that adults do. Adults don't have the best judgment either, but they have better judgment than children do, right?
How much does suicidality drop for trans children who receive gender-affirming medical care?
That's such a massive pivot. I can't even comprehend it. I don't know it for me.
You said if they're going to die, then you would agree with this thing. Suicidality drops by 70%. Is 70% a big enough drop in suicidality to allow these people to receive the care that they need?
No, because the suicidality is not a medical process.
Yes, it is.
That's a psychological process.
Psychology is medicine.
Dude, okay. You're completely missing the point. But
No, I'm not. You said it's not a medical process. Psychology is quite literally medicine. I don't know if you know
It's
this.
not a medical
but
process.
I don't know if you know
okay.
this. I don't know if you know this.
Yeah.
But like, in order to treat somebody for like and prescribe like drug psychotherapy, like SSRIs, things like that, you have to like go to medical school.
Okay.
So I don't know if you know this, but it's a medicine.
Yeah, but okay, I'm on SSRIs, right? My SSRIs do not have a significant chance of making me infertile. They do not have a significant chance of changing my outward physical characteristics.
Irrelevant.
You can't compare SSRIs to puberty blockers. That's
Irrelevant.
apples to oranges. That's a dumb argument.
Irrelevant.
I wasn't comparing
Irrelevant.
okay, enough people paid. You can't even fucking track the conversation.
Bruh.